Oh, yeah. We still have 5 minutes. No, we have 1 minute, rather, 1 minute.
Afebawala University and Lagos Studies Association. And it's particularly important that this kind of convening is brought to life because a lot of times when issues of public health or any public health crisis that you can think about, comes to the fore. We had COVID and Ebola. There's a lot of issues around all kinds of serious infectious disease, Lassa fever, and all of that. Every now and then we have all these crises, and a lot of times the states and those who manage public health institutions in Nigeria and a lot of other African countries often quickly turn to quote unquote public health experts, particularly those coming from the disciplines of medicine or community health, health promotion and all of that. And oftentimes, humanity scholarships, are not particularly reflected on in many ways. But what we have seen over time is that when this crisis happen, what drives the way people behave and how they respond to this public health crisis, depends a lot on cultural beliefs, people's perception of themselves, their being, how they are part of society, things associated with religion, things associated with how people interpret their everyday experiences, which oftentimes is not, in the domain of these so-called first responder in terms of research. So it's why for LSA and those who have convened this particular panel, to bring all of this together and try to show how humanities at the interface, particularly of social sciences, and all of that, sort of help to shape this space of knowledge and show how humanities thinking can help drive public policies associated with public health response, preparedness, and control. So we are glad to be here this afternoon. We are supposed to have 5 presentations, but for one reason or another, we have just 3 presenters here, which is good because we are going to have a lot of time to exchange, to get questions and comments. I can see some faces here. I'm excited already because it's going to be really, really exciting. So to quickly introduce our panelists, The first panelist here on my left is Oluwatosin Mary Adeyemi from the University of Ibadan, coming from the Department of History. The next presenter, for my right here, is Precious C. Ede Madu from the University of Nigeria. She is in the Department of Tourism and Event Management. Oh, yeah. Okay, yeah. Apologies. So there's Chinonso C. Uwadu, who is from the Department of History. Okay, they'll tell us where they are from. So my apologies. I'm sorry. It's not even here, so I try to note it on the program. So apologies again. So we have these three presenters. They are going to be speaking for 20 minutes each. We want to take all the presentations together. What? You have questions? No. Okay. So we are going to take all the presentations together, and when we are done, we'll get comments, questions, particularly from the audience, and then we'll get response from the presenters. So without holding us for much longer, I'd like to invite. Presentation is being downloaded.
Can you start first?
Okay. Okay, so we go to the other side. That would be Chinonso, who is going to be talking about recreational facilities, health promotion, and medical tourism in southwestern Nigeria.
Good afternoon, everyone. My name is Chinonso from the Department of Tourism and Events Management at Babalola University. And I'm going to be speaking on assessing the role of recreational facilities for patient health promotion and medical tourism development in Southwest Nigeria. Please slide view. Now, we are talking about recreational facilities, patient health promotion, and medical tourism development. Recreational facilities, as we all know, are amenities provided in places that people can engage in. It can be found in schools, communities, workplaces, and even in hospitals. But they treat them, when they are found in hospitals, they are being referred to as non-medical interventions or non-medical intervention or psychosocial treatment. And patients can engage in this during hospitalization so that it contributes to their patient's health promotion. Now, this initiative has led to so many policies, like the UK policy named as End Pinjamas. This is noted by some scholars like Oliver 217 and Dog 215, where patients in the hospital are encouraged to get up and engage in this activity in order to prevent functional decline. Sometimes when we're in the hospital, they just lie down, get up, take medicine, and all that. So there have been a shift where hospitals now providing facilities like garden spaces, art and craft, shared board, gym facilities for patients. But in addition to that, the places where these facilities are being provided have a competitive advantage of attracting medical tourists. For example, hospitals in Asia aggressively and actively market these facilities in order to attract medical tourists. There are some studies like HIM done in Korea, 2023. There is Yaga in Turkey, and there's even Oman, a recent study done in Malaysia. And they highlighted one thing, that the availability of this facility help in attracting medical tourists to their destination. And even the United Nations of World Tourism have even noted that medical tourism is competitive. So in order to attract people, you need to distinguish yourself. And so this form, the aim of this study, assessing the role of this facility in attracting medical tourists. But there is a gap. And there is a knowledge gap on the availability and accessibility of this facility in Southwest Nigeria. There's also the gap of the knowledge of healthcare professionals incorporating this facility in the hospital for patient health promotion. And if this gap is not addressed, it hinders or diminishes the efforts of promoting patient health in hospitals and also, limiting the chances of Nigeria positioning itself as medical tourism destination. And so that formed the premise of this study. Now, the objective of the study, slide 4, please. We look at the availability, the accessibility, the knowledge of the healthcare professional, and the influence of these facilities on patient health promotion, the influence and the challenges. The scope of the study involves 2 states in Nigeria, which is Ekiti and Oyo State, and it makes use of 6 hospitals in southwest Nigeria. Slide 5, please. Now, the 6 hospitals, I will explain that during the methodology, and it also involved the healthcare professionals in hospitals. Slide 6, theoretical framework. The study made use of theory of comfort and push and pull theory. Slide 6. The theory of comfort was proposed by a nurse, Klober, in 2003. And the theory just suggests that for patients in hospital, there is need to address some psychological issue. Most times they feel like the medicine administered to them is not working. It's not just about the medicine. They need to be catered emotionally, socially, psychologically, for sometimes the medicine to work. So the patient's comfort needs to be addressed in the hospital. Why push and pull theory noted that people travel because of various reasons. If you research about medical tourism, most times people don't go because of the healthcare professional expert. There are some certain factors that push people to travel. For example, most times medical tourists that are Islam tend to travel mostly in Islam countries because they have the availability to pray whenever, they have the availability of halal food, as they say it. So push and pull theory, why the push factor push people, the external forces for people to travel for some certain factor. The pull factor is the internal factor that pull people to travel. The research methodology. This is the research design. Quantitative and qualitative method was employed, which was interview conducted in Ministry of Health, Ekiti and Oyo State, and Ministry of Tourism, Ekiti and Oyo State. The sampling technique. Stratified and purposive sampling technique was used in selecting hospitals in Southwest for this study. And the first stage was stratified, where the hospitals in Southwest, which are tertiary hospitals, not just every hospital, they must be affiliated with universities, not just every hospital. And there will be federal. The states will have a federal teaching hospital, a state teaching hospital, and private teaching hospital. Like I said, they must be affiliated to a university. And the reason for that is most of these tertiary hospitals have many wards and consultants, experts, and our medical students, this is where they are being trained. And so with this method, we come up with 2 states that make up with that standard, which is Ekiti State and Oyo State. So in Ekiti, we have Ekiti State Teaching Hospital, Federal Teaching Hospital Ido, and Abwa Teaching Hospital, multi-system. While in Oyo, we have the UCH, the Bowen Teaching Hospital, and the Lautech Obomosho. So those are the hospitals used for this study. So each of them federal, state, and private, so that you can see the spread of the facilities they have. Now, the population of this study is 3,914 healthcare professionals from these 6 hospitals as of 2023. And the data was gotten from each of the hospital admin units. But that sample size is too much, so I applied using Taro Yamani, and I have 362. Now, 12 staff were interviewed from the different ministries. Descriptive analysis was used, while linear regression was used to test the hypothesis. Interview was analyzed thematically. The research instrument was questionnaire and interview. Now, data collection for hospital was using snowball sampling. And the reason is this: I do not know the healthcare professional, so I meet one, introduce, okay, this is a doctor, this is this. Reliability and validity test was conducted and it showed internal consistency. So please, finding and discussion. Slide 8, please. So this is the percentage distribution of the questionnaire. While slide 9 showed the analysis of the respondents of the professions, which are doctors, nurses, radiographers, pharmacists, and so on. Slide 10. So for the research objective 1, I looked at the availability of different recreational facilities in this hospital for patient health promotion. And these were the findings. And interestingly, television was more in all the hospitals. And I found out the reason is most of them were donated, maybe by youth corps members, mostly. You see that in the hospital. And we have reading books, mostly Christian reading books, which were donated by maybe people that come to visit, and religious facilities. And some of them don't have a building, but they have a place, they station. Like if you come to Harvard Hospital, there are a place that you station. If you want to pray as a Muslim, you'll be assigned there. Okay, you can have your prayer. And these findings are consistent with some studies I reviewed during this study, but especially religious facility. It has a historical significance because sometimes people want to atone for their sins because they feel they want to, pass on, and they feel at peace when they maybe like the Catholic, they do a kind of confession and they feel like, okay, I can now pass peacefully. And the historical significance with chapels in hospital, it addressed both psychosocial and social needs. Slide 11, please. Now, during the interview, for availability of facilities, something was noted that it should be departmental specific. The people interviewed noted that facilities provided for cardiac people should not be provided probably for gynae ward. And facilities provided for gynecology should not be provided for children ward. So it should be departmental specific. And looking at the question 2, the ease of accessibility, where they are present, patients can easily access that. But there is no designated hour when they can use that, and there is actually no feedback to that, and that becomes a problem. Some also stated that they are being charged money, but when I interviewed in the Ministry of Oyo, the man there, the director, said he cannot lay claim to that, he does not know. Hypothesis was tested, and it showed there is a model association, which means there's effects of ease of accessibility to patient health promotion. Now, coming to knowledge, there's actually low knowledge of healthcare professionals. Some of them don't actually, when you check the questionnaire, some of them mark neutral if you should put this in the hospital because they are not certain if it should be there or it should not be there. Now, during my questionnaire distribution, I tend to make but one thing I observed is when you go to most of these hospitals, in all the mental ward, they have this facility because they feel like these are the people that need it because of their conditions. So there is a low knowledge of this, about this facility being incorporated in the hospital by these people. Slide 12. Now, on effects of these facilities on health promotion, there are many findings. It helps in fast recuperation of these patients, help in mental and emotional stability, lengthen severity of disease, positive distraction, and the hypothesis actually show a strong positive relationship. Some may argue, oh, we're in a hospital, why do we need a recreational facility? But actually it's needed. In fact, when consulting this study, one of the consultants, Dr. Day, oncology consultant, said it should also be extended beyond the patient to the patient relative because sometimes they even feel idle at the hospital. So these are the effects of these facilities from the finding on the patient. And does it help in medical tourism development? Of course, yes. It helps in appealing the place, satisfying, creates revisit intention. People can recommend. Most people that recommend, during my interview, the ministry said they are working with UCH to build a wellness facility at Agodi Garden so that people can be, if you don't want to go to UCH, depending on you can be bring to Agodi Garden at the wellness facility. I don't know if it's still ongoing because they were doing the negotiation there. And the hypothesis results also show positive effect. Where these facilities are, sometimes people just travel because of these facilities, not just, and there are challenges, space, insufficient funds, and administration. So in conclusion, this study not just shifts our focus that it's not just the medical intervention that work on patients. There is need to incorporate this non-medical intervention in hospitals. And hospitals where they are being provided have that competitive advantage in attracting people like medical tourists. So this is one of the videos some of us know apropos doctor. Please, the next slide, you can play that video for me. When he had a brain tumor and there is this him playing a chessboard in the private hospital he was in Lagos. So this is kind of thing, this help in hospital. And the other slide, 15, this was a movie I was watching, and this is a doctor playing a chessboard with the patient. If you look at that, this is observation day 04. So from 01, they keep giving her different facility to test her mental ability. So slide 16 is a hospital in Australia that have a garden. This is a garden people can sit out if you are bored in the ward. And slide 17 is also a hospital facility where people can throw the arrow ball and snooker, which also help in promoting patient health beyond just medical intervention. Thank you for listening.
Thank you, Chinonso, for your presentation. You saved us about 5 minutes, which is good. We'll have more time to talk. We go straight to Precious' presentation, which is titled Inequality. You want to go first? You want to reclaim? Okay. Are you okay with reclamation? Okay. So Mary Oluwatosin Mary Adeyemi is trying to reclaim her position, and she's going to be talking about from short to post-colonial struggles, vaccination policies, colonial medicine, and health resistance in Nigeria. It's from History Department, University of Ibadan.
No, that's not what. That's how that's precious. This one.
Okay, you can start.
All right. Good afternoon, everyone. Good afternoon. I'm so excited to be here. Anyways, so this is actually a work in progress, and before I start, I would like to say that I'll appreciate any suggestion, observation, and recommendation. Thank you. So I'll be presenting on from short to post-colonial struggles, vaccination policies, colonial medicine, and health resistance in Nigeria. That's a lot, right? But anyways, you can look at the pictorial representation of this image. Now, this is a young child in, let's say, 30s, in the 30s or 50s, early 50s, trying to take vaccination. You can see the instrument that's being used on this child. I see it being that the child is scared of what they are doing to him, but I think it's like, oh, probably it's something everybody is doing, but he has to. So now that is where the inspiration of from shots, taking shots to post-colonial struggles. Now, next slide. So introduction. This study examines both colonial and post-colonial vaccination policies in Nigeria, analyzing how they were shaped by broader structures of power and control. It focused on different forms of community resistance to these policies, particularly in relation to indigenous healing practices and local understanding of health. It is also grounded in archival research and oral histories. This project, or let me say this paper, aims to highlight how public health interventions have historically functioned, not only as a medical initiative, but also as instruments of governance. Now, the next stage, historical context. Looking at colonial medicine in Nigeria. Now, this is also another historical example. It says, if you look at the text in this image, it says, have you been vaccinated this year? Now that is a mother with a child on her back, and you can see the person giving the vaccine. It's not, the person is not dressed as a nurse or a medical attendant. It's dressed, this you can probably guess that this is a colonial master. So the Victoria image is trying to say, okay, this is a colonial master brought this vaccination initiative, and this is a mother in her, indigenous attire trying to, do this for probably herself and her child. So now it says, be vaccinated and make it a smallpox-free game. So now, I mentioned earlier that health interventions became a tool of governance, right? So it's something that, okay, while the colonial masters are trying to, govern colonial Nigeria, they brought in initiatives as their own incentive that while we are governing you, you also have to do this. Even though, as of that time, fine, it's for their own safety, but it's also for in order for them to maintain, orderliness and also govern the citizen as of that time. So now it's now progressed into, medical authority. It became intertwined with imperial power. Now you see the chief medical and sanitary inspector and probably the governing council working hand in hand just to ensure that people get vaccinated and also orderliness is maintained. So now, vaccination, colonial medicine, it was also introduced under the guise of public health and order. Because as of that time, in colonial Nigeria, across colonial territories, there was a flame of, different health issues across all colonial states. So they're just trying to maintain like a public health order whereby, it won't affect the administration, and they will also be able to govern effectively. Next slide, please. So now, looking at 1917 vaccination, I mentioned earlier like that the vaccination was now framed as a civilizing mission. I don't know if can you vote? Okay, next number 4. Yes. Then we can zoom.
No, just read.
Okay, you can do. Okay, all right.
Just
fine.
project.
So this is just
Project
I can't see, this is just a snapshot of a correspondence between the director of medical and sanitary service and the chief secretary to the government. So yeah, it's fine. So I will just read where it says that, okay, reference your wire asking me to define an area for compulsory vaccination. Since receiving it, I have seen the DDSS and have talked the matter over with him. It is a very difficult question to answer, and in my opinion, I suggest that vaccinations should be left as they are at present until the pagans around in the different areas of, okay, now this is around railway construction. Areas of the railway construction are beginning to realize that it is good for them, then vaccination could be made compulsory. Now, in this correspondence, you can be able to deduce the fact that, fine, this is something they want people to do. However, they were met with resistance, and they realized that there is little to nothing, that there's little to nothing to what they can do, except the fact that, okay, fine, we said you should do this, but there are retaliations. Okay, if you come around, that's fine. Until you realize that this thing is good for you, then we go on with it. So this is just like a snapshot of difference and a lot of correspondence amongst these officials as of that time. Now, legally enforced, another key focus is also legally enforced inoculations. Like people were, they were enforced to take inoculations in order to, like, for instance, when there was outbreak of smallpox as of that time, people were taking inoculations to, resist this the spread of this disease. Then also, this vaccination ordinance is also, it was an instrument of control, not just an health policy. Now, the case study is southwestern Nigeria, whereby we have various campaigns on smallpox and yellow fever. And in southwestern Nigeria, there are, strong traditional healing system. For instance, for smallpox, as of that time, there were traditional methods of, treating these diseases. But when the British came with their own, method, their own vaccination, it's people were wondering, okay, so what about our own methods? And at that point in time, when they call people for vaccination, people don't show up, except if they probably use shows like probably baby show competitions or probably things to entice them to come around to take this vaccination. But as of that time, it was not easy to convince people that are used to taking, their own medicine or their own traditional methods of treating this disease. It's not easy for them to just accept this strange system. Then also another resistance is framed as cultural defense, because they are trying to protect their culture and seeing the fact that, okay, the whites are coming with big machines for them to take vaccination. So what happened to what we've been using before and the likes? Then also villagers, most especially in the areas of southern West Nigeria, like villagers, they resisted this vaccination because it was like an intrusion, like they are intruding in their space, in their cultural beliefs amongst the likes. Next slide, please. So this is more like a pictorial representation of people queuing, like this first slide. You can see mothers having a queue, trying to line up. Then the other slides, you can see people trying to line up to take vaccinations. Now, indigenous knowledge versus biomedical frameworks. Next slide, please. So they, with time, it's it's evolved into contrasting views on health. Like for instance, there is this traditional spiritual approach to it, and there is this Western biomedicine, and like it became like a clash, because there are some people they just want to stick to their own practices, while some people are just there trying to ensure that people comply. As of that time, we also have traditional rulers in which the colonial masters use as a means to enforce people to come around to take these vaccinations. So, and at that point in time, even traditional rulers, they came around because they had to encourage their people. They came around to also take this vaccination, but it didn't give what was supposed to give as of that time. Then also there was lack of consultation and dialogue. For instance, in the interiors, like in the villages, there was no people. Like for instance, let me say, okay, there wasn't like an intermediary to encourage this mother. Okay, this is what it's meant for. It's just, oh, you have to take this. It's compulsory. If you don't take it, you will not be this. So there was no proper dialogue amongst these villagers and these, and so cultural alienation in public health strategy. Like they just want people to be vaccinated. They didn't take into cognizance the cultural importance of, integrating their public health strategy. So now continuities into the post-colonial era. Now we have legacies. Next slide, please. Thank you. No, the previous one. Yes, thank you. So legacies of colonial health policies. Now, the global health agendas still often ignore local realities of these villagers, and even till date, we go into the interiors of these communities, you realize that they have little to no idea of what vaccination is about. They just know that, okay, they ask them to come, this is what they say they should do, and this is how they should do it. So there is no proper integration or information. So also there's distrust of external intervention. Yes, like I mentioned earlier, the interventions, fine, they are trying to curtail the spread of smallpox, the spread of yellow fever, but there was no, they were unable to gain the trust, because fine, the people they are trying to vaccinate, they have this impression that they are trying to, alienate their culture, trying to extract, like to make them, forsake what their traditional beliefs on how to heal these diseases, how to cure them. So at least before the colonial masters came to Nigeria as of that time, there were ways, there were medicine, there were herbs that they used to treat themselves. So then also standardization versus cultural sensitivity, ethical challenges in vaccination and AIDS campaigns. Then also now, this last statement is very, very important because at the end of the day, you realize that okay, whose knowledge actually counts in these health decisions? We have the colonial masters, they have they are trying to pass the information that okay, yes, you have to get vaccinated. Then you also have the traditional rulers, they're trying to obey the colonial masters that okay, in order to govern your people, you have to tell them to do this, you have to tell them to do this. At the end of the day, then you also have the traditional medical practitioners trying to let the people know that no, this thing will not work for you. Or you also have some situations whereby they even take this vaccination and at the end of the day they die or they don't make it or they have another, the way they react to this vaccination is something that is not as expected. So they are now conflict information on okay, who should we trust, who is passing the right information, or what exactly is this about. Then now the key argument of this paper is looking at colonial vaccination as a tool and form of governance, and also that the fact that vaccination campaigns were also part of colonial governance, like a broader colonial governance. And also another argument that this paper posits is the fact that indigenous resistance was both cultural and assertion of health sovereignty. Then moving on, this paper acknowledges the fact that post-colonial policies still echoes colonial ideologies. Because at the long run, if you go to UCH today, you see a lot of people that fine, maybe they come all the way from probably, let's say, Gbogbon, somewhere in Ibadan, like an interior part of Ibadan, and they come to UCH because of a particular ailment. Like you still realize that they don't really have that information, but they just know that okay, they said you should come here once we are here, that this is going to be done. So the aftermath of these ideologies is still inherent in our present community. Now, I also noticed that there was a shift because at the beginning of this paper, when I showed the pictorial image of the boy with this heavy machine collecting his vaccination, but here you can see that okay, it has evolved. You don't even have to use that scary machine to take vaccination. You can actually take something like this, and you can see a line of people sitting down to also take vaccinations in their community. Then also you can see that the instrument has changed. Can you move to the next slide, please? Thank you. You can see this is just like a needle whereby a baby is being held by its mother to collect this. And likewise, the second image. Then in conclusion, vaccination in colonial Nigeria functioned not merely as a health intervention, but also as a tool of political control embedded with broader colonial strategies of governance. Now, community resistance to these campaigns was not rooted in ignorance, but rather in a conscious defense of their own cultural autonomy, traditional healing practices, and indigenous understandings of health. Now, the legacies of this colonial medicine continue to shape public health in Nigeria today, as it is evident in the persistence of top-down policies that often neglect local context and voices. To move towards truly equitable health system, there is an urgent need to rethink public health frameworks while embracing storytelling, cultural humility, and community agency as foundational elements of care and policy design. Thank you.
Thank you for your presentation, Oluwatosin. Some more minutes saved. This is good. We go to the third and final presentation on this panel this afternoon, and that will be delivered by Precious on inequality and exclusion, the effect of colonialism on public health practices.
Okay.
You have the floor.
Thank you, everybody. So yesterday I was in a panel on maternity distance. So someone said something about whack, that our traditional practitioners that they are whack based on midwifery and all that. So a question came to my mind. Okay, I said yesterday I was in a panel based on maternity discussion. So one of the discussants said that the traditional practitioners that they are whack. So a question came to my mind. I was like, why we Africans be calling our own this thing whack? Like before these people came, there was something existing. So and then with my own experience, when I was in SS3, because I was involved in an accident with my cousin, and what we saw in the primary health care that the Europeans helped us to form during the colonialism was something that I cannot really explain very well. So my topic on inequality and exclusion, I'm trying to trace the effects, how this thing started. Okay, so I'll say that there has been a resurgence of poor public health practices that were a product of colonialism, and historical evidences explain that the current state of public health system in Africa. So this paper uses Nigeria as a case study to explore how colonial policies have resulted in an unequal health resource distribution, particularly between the urban and rural areas, and between the affluent and the underprivileged people. So by revisiting the colonial healthcare frameworks, that significantly did what influenced the Nigerian public health system. So please, the introduction. Okay, so prior to colonization, Nigeria, we have diverse ethnic groups and we have so many ways of attending to our health issues before colonialism came. So, and then we have the traditional experts. They know how to give birth. They know when you are sick. They know what to do to you. So they kind of take care of our tripartite being, both spirit, soul, body, everything. These people were in charge before colonialism came. So our initial contact with the whites was supposed to be something positive to us, something that is supposed to help us, but it rather turned out to be something else. And then colonialism inflicted immense suffering upon us Africans, especially Nigeria, and my case study is based on Nigeria. So it really gave us a mark that before we can erase that, we have to trace it to every root, because every aspect have its own discussion to be talked about. So with their policies. So the colonial administration's approach to health was rooted in prioritizing inequality, exclusion, racism, and discrimination based on class and status. So health infrastructure was primarily developed in colonial administrative hubs such as Lagos and Enugu, leaving the rural areas like is with time that they started going down. Not them, is in the post-colonial time. So in 1960, Nigeria inherited the urban-centered health system and continued the marginalization that the colonial officials left for us. Okay, so the next slide. So I want to talk about the formation of public health practice in Nigeria. That is the colonial effect. How did this thing all started? So I believe that when I said quack, I believe that statement quack started with this background with colonial officials present in Nigeria. So they used this medium to do what? To navigate the trend. Actually, why they even started the hospital here was because malaria kills them. They had a lot of allergies to some of our environment because it's a tropical region. So they had to look for a means to survive in this place so as to be able to achieve their exploitative motives. So they had to invent so many vaccines, and that's the vaccine my colleague was talking about. So many of them, so many vaccines during that time. It all started that time. So the British colonial government, they dignified the health care through their West African Medical Service that they established during that period. Okay, they also made use of the missionaries. So there's something that I noted: the gospel and the plow. The missionaries that came, not all of them, in fact, majority of them came with exploitative motive. Not all of them came actually to spread the gospel. So most of them came with their own motive. And as a result, the colonial officials used this to also do what? Exploit Nigerians. So this West African Medical Service, that they established was supposed to incorporate both Africans and the white doctors and nurses. But unfortunately, one of the requirements for you to be part of that WAMS was that you must have gone to school in London, of which is not possible for them, as at that time. We Nigerians, they were like, how we did? So they were sidelined, when it comes to hospital and all this. And they had the hospitals, the most, the well-structured hospitals and all these things was in the quarters of the European officials. Like Africans, we are not really, their picture was not in mind with the formation of these hospitals and the public health system here. So the medical personnel needed for the hospitals were mostly the whites. So although some blacks were trained, they were trained to be doing the menial jobs. And then they were also serving as a slave to those white doctors. So now African doctors in practice were given so many restrictions. That's where this segregation policy comes in. So if you're a historian, or some of us must have heard it, we have even presently, if you travel to some places, you see that this environment, say this is where the Europeans were living before we gained our independence. Some of those landmarks, they are still there. So the outbreak, but when did these people started incorporating like giving real treatment to Africans? Was because of the outbreak of the Second World War. They needed us for soldiers to represent them and those that work at the mines, to be able, because they noticed that if this person dies, nobody will work at the mine again for them. Like they need able-bodied men. So as a result of that, they had to extend their policy to incorporate only those who will serve as soldiers and those people that will help them, to dig out the mines and all that. So now, so many ordinances were also made. Like we have the punishment ordinances, we have the venereal disease ordinances, and the sanitation ordinances and all that. So now this modern medicine, as it's called, dismissed and suppressed the traditional healing system. They were threatened during that period because people were like, what's this? They prefer going to their normal medicine that they know. So they trusted those people and they depended on their normal traditional healers and all that. But the Europeans, in fact, I think there was a law that they made against such during that time. Yes, they made that law. And anybody that goes to those that practices that during that period, they were threatened. I believe some of them were punished. That's where this punishment ordinance came about. You understand? It's part of it. So they were punished, and some were even sent out of that vicinity and all that. So, and anything you are doing that is standing as a bridge between them and their motive, you'll be punished regarding the medical system. So, next slide. Now, I want to talk about the post-colonial healthcare structure and the policies, like after colonialism and all that. Yeah. So Nigeria inherited this inequality and exclusion, the marginalization, the discrimination. They continued with the trend with our independence in 1960 because there were no form of major changes or anything that they did because it's still in existence till today. Okay, so now the post-colonial government continued to rely on the existing infrastructure, which was ill-equipped to address the diverse health needs of the population. And yesterday, when one of the discussants was saying something, she said something that they don't have funds. She's a midwife in one of the health cares, public health cares, that there's no fund, okay? And they need this and that. There were so many things that she said, and it's in line with what I'm discussing, because this is the effect of colonialism. They did not do anything about this. Okay, so now the bequest of colonial healthcare policy in Nigeria has been both profound and enduring, shaping the country's public health landscape long after independence. While colonialism introduced new health technologies and infrastructure, the structures and policies left behind also entrenched deep inequalities and systematic challenges that Nigeria continues to struggle with today. Okay, so these structural inequalities are evident in in persistently high maternal and infant mortality rates. If not because of God, my cousin would have died during that period. Yes, I was looking at her in that hospital and looking at the doctor, I saw what I saw that there was like, is this really an emergency ward or is something? Because I was conscious. So all these things are effect of this colonialism on us, on our health system. So these structural inequalities and all these things is embedded already. So the disparities in healthcare access are further influenced by individuals' living conditions and which are shaped by political, social, and economic factors. And as we all know it, we have the poor people, we have the rich people. Some of us don't have access to those primary health care as they are in urban areas. And then inside the villages, where are the hospitals? If you visit those hospitals, what the primary health center and all that they call it. If I let me use my own village as an instance. I know so many people that have died in the same primary health center. No equipment, nothing, based on what she was saying as part of it. Nothing is there. So it's only the affluent ones, the rich ones, when they go to the hospital, the way they take care of them because their money is speaking. What about those people that don't have the money? What will they do? How are they supposed to? So these are all aspects of it. So when the government tell us that they provide this for us to send to the rural areas and all that, check it very well. When you go to those places, those things are not there. So where is the money going to? And that was the same thing the woman was saying yesterday, that maybe the government will bring out the money, but the money will be nowhere to be found. All right. So with the introduction of SAP and all the IMF and Bretton Woods, policy in Nigeria began to service debt. So, and then all the sectors like the loan and everything affected everything. So the health sector and most other sectors became what I termed like they died. Improvements died. Like there is debt in that area because everything, they'll bring out money, they say that they're servicing debts and all this. In fact, there's no form of transformation that we are seeing after this colonial period. So the result was loss of qualified doctors and medical brain drain. Yes, most of their doctors, they are in US, UK, and all this, and trust UK and US. They don't value you if you're not adding anything to them. And because they need you, they'll do everything possible to keep you there. So there's no reason why you should leave that environment. So if you check, just travel, Google it and check. Most of the health practitioners there, they are Nigerians. Yes, and so many of them are still living. That's why you go to some hospitals, they are maybe you just be seeing few doctors and all that. So some people that are just around, some of them, if you interview them, they'll be telling you their own story and why they might even, they need to leave. Everyone needs to leave, to go to a better place where you'll be appreciated and valued. So privatization in Nigeria also worsens the problem. When everything we now have private hospitals, we now have private this, private that, private this. In fact, in a private hospital, by the time you finish buying cards, getting a card to be attended to, the amount you are going to drop. And so the poor person cannot go there. Even those hospitals that they say they are sharing, some medicines that they share free is not relevant to what is happening to the person. Okay, it's just thank God for some NGOs that are actually helping out, but it's still not going deep to where it's supposed to go to. So, okay, so privatization wasn't the situation as only the haves have full access to private hospitals in Nigeria. So in conclusion, the colonial health care system structures and policies created a blueprint marked by exclusion and inequality. Although they introduced some achieved advancements, the after effects have constrained Nigerians' ability to build a full, inclusive, equitable health system. Recognizing and addressing these colonial legacies is crucial for meaningful health reforms in Nigeria today. So therefore, enhancing public health care through the decentralization of services to local government areas can increase access and responsiveness to the needs of the community. So incorporating the traditional medicine into official health system can also can improve cultural relevance. When I mean incorporation, I do not mean that they should join them and then they should now start drifting from their traditional practices that, medical this thing that they are practicing, which are relevant, into the westernized form that might affect the system. Yes, because I raised the question yesterday. I was like, when you talk about collaboration and complementary, like having a formal training, because there was something one of them said you need to have a formal training, that the traditional healers should come and have a formal training. I was like, when you say formal training, what do you mean by that? Okay, so maybe they are trying to, because definitely with Nigeria, we know they'll try to teach you their own system. They want you to start practicing theirs and drop yours. So my question is there going to be a room? Is there any room for them to, let there be a collaboration, like when you are working together, everybody on their pace, learning from each other and, producing meaningful results. So widening the scope of the National Health Insurance Authority or scheme and also decreasing out-of-pocket costs can make health care more affordable for every Nigerian. So thank you.
Thank you, Precious. Thank you, Oluwatosin. And then thanks to you, Chinoso, for a very beautiful presentation. You've all been very, very articulate, and I'm sure that the audience have enjoyed your work. To some, really, starting from Oluwatosin, we have listened to issues around vaccination policies, colonial medicine, and health resistance in Nigeria, where issue of the impact of power and control in vaccine interventions, have been laid bare, particularly how people resisted on the ground in the context of Southwest Nigeria, I believe. And then also, Precious, who just finished a presentation, talked about the effect of colonialism on public health practices. And she placed a lot of blame for on the doorstep of colonial infrastructure, colonial thinking about medicine, colonial inclusion and exclusion in terms of training, as shaping or what we are still witnessing in post-colonial Nigeria in many ways. And now there's transference of such practices, of such thinking, of similar imaginations on how people were able to access healthcare or not in Nigeria today. And Chinonso very beautifully also talked about the need for recreational facilities within the healthcare setting, and how, if brought into health promotion strategies, can also facilitate medical tourism in Southwest Nigeria, drawing from mixed research design, combinable quantitative and qualitative work. I'm sure you will have comments because this raises the presentation raised a lot of issues. To what extent we can talk about colonialism, how much impact should it be having today, whether or not is a necessary lens to critique public health practices in contemporary Nigeria. So we want to hear from you, questions to them, comments, but we should keep in mind, these mostly are ongoing work, and we should, as much as possible, help them to improve on the work. So we want very constructive feedback from all of you. So we go this way. So I look at this column, we take some questions there first, and then we come here, and then we come to this place, right? So, and I see one. Okay. Okay, so we take, okay, we have three here. So we take the first three, and then we let the response go, and yeah. What's that? Online? So we just hold on. So what we want to do with online is kindly put your question in the chat box. So they will be read out, and that's how we're going to approach it. So I take the first hand from the back. Yeah, please. Please come here. Biodun, please, can you increase the volume? Because people are online, we want them to hear you too.
I have this question for questions.
Okay.
I'm not the medical or health practitioner, but I'm getting feedback from literary theories, reality, and post-reality. I said, coloniality brought modern medicine to our doorstep as one of the colonial legacies. And are you situating your paper on the trust of traditional medicine campaign? And then I said, what about the exploration of the strengths coloniality has brought to public health? I said in Nigeria and Africa at large, which over time has improved the lot of modern medicine administration and rapid improvement on public facilities. This is so precious. And I said my own solution. So I see no exclusion on inequality because many severe spiritual conditions are still, even today, handled by Australia medical practices. Even there are some cases in the modern medicine in the hospital. Okay, some of those exotic ones are cited by Chinon, so UCH and Sandra. Say we cannot handle these complications. Please, Dr. Sele, take it to one traditional practice, what's it called now, homes, where this is taken, where this complication is taken care of. And then you mentioned brain drain, JAPA function. What has that got to do with your paper? Because it's becoming multifaceted. So I think you just have to streamline and get the trust and the contribution to knowledge that your paper is actually addressing the lacuna that your paper is actually trying to do. I say again that whether medicine application
Biodun, you have to wrap up now, please.
Modern medicine application or medical application is a matter of choice. What about the financial factors and implications? And to chin on, so I say, what about the financial implications? Fine, your presentation beautiful, your recommendation fine, you see a short of that. But what about financial implications attached to getting and seeking medical attention from those sampled hospitals where there are recreational facilities and that are quite exotic? And I say, what about common general public health? People commoners who have money to access these facilities. What about our local public?
Thank you very much, Biodun. Thank you so much for your contribution. Thank you, Biodun. Let's all go, please.
And it's not really exciting, but I'm more concerned about the post-implementation. And it's a good work. Why not? And I know it's not one way to know this thing, but I want to call your attention to certain things. I think we also need to interrogate the issue of social change when it comes to public health, whether you are talking about the African traditional health system or you are looking at public health as it concerns the Western medicine, this sense of social change in terms of technology, in terms of presentation, in terms of education, how it relates to resistance. Because now you know that traditional, our drugs or medications are being packaged in such a way that it's like that of Western pharmaceutical drugs. So I think you need to look at the place of social change. And I also want to say that maybe you also want to look at resistance and ignorance and want to use them as explanatory framework to this, this study that you are doing. Then you may also want to read the work of Elisa Bennett. When I have MD, she has done a lot of work on what she has presented. And I think there are some things we need that may also contribute positively to what we are doing. But
Thank you so much, man. Thank you.
My question is to thank you for the presentation.
My question is, I want to know that you are telling clearance. Yeah, as something the person that you show them in the slide so that you keep your safe.
Okay. Okay. We'll take more questions here. Okay. No, we'll come to you. I'm just seeing you now. So we come here. Dr. Tulu.
Thank you. I want to thank all the presenters for great presentations. I have questions and comments for all three. For Dr. Chensu, I don't want to hear what the gentleman said, but I didn't really see the connect between medical tourism and the other educational facilities in hospitals. But the study on the availability of educational facilities is novel. It's novel, it's new.
Yeah.
And I think it should stand it.
Mm.
It has sufficient merits.
Yeah.
To make some central contribution to knowledge.
Mm.
Right? So I think you should just stick to that. Right? Then in your presentation, your verbal presentation, you did say interviews, but you didn't share any of the findings.
Yes.
Yes, because what you saw, what many of us saw were statistical results, results from your statistical analysis. But I think you can also reinforce it with some of the financial content in trade. Then the very fundamental question, where does the sport stand? Where that is. Right. I saw you share images of very nice, eco-friendly hospitals. But more important, where does the work stand? Does it contradict, does it confirm what's the new thing that your study is bringing to the table? I think you should reflect more of that. Then to Precious, thank you. I was thinking, I also want to make just some suggestions that will make it to also the work. And these are specific areas where I want to use. What is the central question? I'm not a historian, and you shouldn't forget that research is a universal language. Right? So everyone outside of history should be understand what we're doing. So I think you should let's have what's the central question, and then what was actually the research design. Because I found it difficult to follow what you said. Although I understood what you were saying, but the research design, I don't clearly see that. And also the methods that were used, right? So also need to spell that out again. And of course, I'm talking very, very interesting story. And of course, very nice images. Yeah. The question I have for you is, how does the past actually inform the present? Okay. And even in the future, how do you see all of this play out now? Is there, you see any connection with what happened 5 years ago, maybe 3 years ago? And that's with respect to COVID-19 vaccination, right? And then we've also had episodes in this country, although they were not the Southwest Nigeria, the drug trial of 1996. The polio boy, I also have my colleague here mentioned in his presentation. She got a very fantastic piece on the 12 words of polio vaccines in other something. Yes. So you need to actually connect the dots. The work and also follow this. Then I think you also need a bit more detail. All right. I believe that many of your assertions were informed by specific historical events. But I did mention that there were some traditional rulers who were possible. Who are those traditional rulers? You understand? Any people have their sounds of interviews or have their history to be shared. And it's just a rich history of it makes us know that some very, very good historical analysis.
So we'll let them respond, then start from the back for the next round. Okay, so we'll take. Can you read out the questions?
The comments on last time. What are your evidence of punishment on the use of traditional medicines during lockdown? You mentioned There were several policies or what that prevented their own kindly mention these policies. Also, don't forget that native administration or native authority had the power to establish health-related facilities. Or we are under serious inspection and supervision for these facilities. Kindly also check the native administration on that system. Then she continued by saying punishments related to professional medicine came in situation of witchcraft applications or murder.
Yeah. All right. So we start from you, and then we go this way. Please, she wants you to start from you. So you have just 2 minutes, please.
Okay, thank you, Mr. Biodo, for the challenges, for the finance you talked about. The hospital mentioned one of the challenges of having this facility, its finance is one of, but for the patients admitted, they don't need to pay to use this facility where they are being provided. That was why I said, when I was presenting, I said one of the patients mentioned they were asked money, but during my interview with the Ministry of Health, they said they are not aware that there should be no money, or they can never deny or but where they are, they don't charge anything. For ethical approval, I got ethical approval from all the hospitals to use this, but for the video of approval, it was online. It was online. He posted it himself on Instagram when he was sharing his testimony. So I got it online from Instagram. That's where I got it. Okay, credit shopping.
Okay.
Yeah, I got it. Sir, I thank you for your comments. I agree that the promotion, health promotion, should stand in a medical authority, should stand alone.
Okay.
Okay, the new contribution is kind of, when I was conducting the interview, I found out that most of the healthcare professionals actually know that this is obtainable in Western countries, but they do not know. So it's raising that awareness in them that what is obtainable there can equally be here too. And that is why one of my recommendations should be the education and training for them, that this should be in hospitals for also patients.
Okay, thank you for the contribution and question. So you asked me a question about the positive impact. Actually, my conclusion, I said something about that there was an advancement, like they had positive impacts. You understand? Colonial period also had positive impacts, okay, in Nigeria. But I'm just trying to highlight something. That's what the paper is say ongoing, Sha. So I'm just trying to highlight something. So that's why. And regarding funds and all this thing, I said something about why these funds, because of the debt we are servicing, is actually affecting the the distribution of funds to different sectors. I said it when I was saying something. Then, sir, thank you for what you said. So the aim of this paper is actually to eliminate the reasons, that is the trust, for the ongoing health disparities today. Okay, that's the reason. And then why such restricted access to quality health care still exists in a way. So then my methodology is that I'm using a qualitative historical methodology in conducting the research, and also focus group discussions and oral interviews. So that's what I'm using. Thank you. Then the person that said something online regarding the policies and all these things, like I said, I'm still working on it. And when, to my understanding of policies, is something that somebody said, made it as a law, and brought it out that everybody is doing. You understand? Like like the ordinances. Okay, some of them we are formed, like we are used as part of the policies, like segregational policies, things that those things, those things, that's what I mean. But when I'm talking about the policies that they laid down for us, and unconsciously in a way, we Africa, we Nigerians, we are still following that line. Okay, that's what I'm trying to say. And I don't know whether I've answered.
All right, Tosin.
All right, thank you. Thank you so much for the contributions, and I really appreciate that. So back to what Dr. has asked, how does the past inform the present? And even in future, how do this play out? Then looking at I'm an historian, so I understand the fact that history plays an important role in our community. This is what informs us the information of the past informs us and, enable us to do better presently, and also, our future, it also shapes how our future will turn out. So regarding this topic, look, I was just looking at from short to post-colonial struggles. So it started with vaccination, then what is happening in present day, post-colonial struggles, what are the struggles? Although I actually didn't, you know, talk more about the post-colonial struggles at the end of the day, but my colleague actually spoke, about it. So now, is there any connection? Yes, there is connection between, these disparities, in the sense that, then during the colonial period, there was an era before the colonial came, we had our own practices. For instance, I think I think this what's it called? There were herbs that they used to cure these diseases. For instance, this shokono, there's shokono. As of that time, there were herbs they used to cure, and there are some certain things they observe to cure this disease. So, but when vaccination came, it met with resistance, but they accepted it. Then thereafter, after let me say after the colonial, that's post-colonial struggles, looking at the fact that okay, there was more like a conflict between traditional practices, even currently now, traditional practices, and even the colonial practices. I don't know if I get that.
Yeah.
I don't know.
It's okay.
Okay.
Just,
So I really appreciate the contribution.
Sorry, there's
But
no, regarding what.
no, you can come back to it later. So we'll take questions here. So please, the next set of questions should come or should be delivered in 30 seconds. Max. So red cap, gentleman. Please, red cap, man.
I'll try my best. Of course, a suggestion to the colonial lady, not master. You might want to read Shaya Bibala's book, The Foreign Days. The introduction of that book can help you do
Yeah.
your introduction.
So yeah, Bimbola.
Shaya Bibala, yes. The second thing that I noted down here that countries' inabilities to develop their health system post-colonial period, has further tied them to dependence on this colonial states. As one example is cited in 19, most of the interventions to add in a country like Nigeria were largely based on donations. And the author also mentioned the Truban case in Kano. We were treated like guinea pigs. So that antibiotics have been tested on adults, but have not been tested within pediatric settings. At the breakout of meningitis, they just brought in because we had nothing to do with that. So it was free drug for us. And then out of 200 children that were selected, 11 died within months. And it was taken to court. And then at the end of the day, the Kano state got about $70 million compensation.
Time. That's it. That's it. We have to go. Time. No, just for everybody. Just no, please. Let's keep it short now. We still have a lot of people waiting to make comments. So we take you and then we move backwards. Yeah.
I'm just interested in the concept of authority and how does that also translate to economic development, also how does that translate to undeveloped spaces where we speak to that fusion and attract foreigners, how does that affect social undevelopment? Then for the second presenter, thank you so much for your part. I'm just interested in hearing the question of improvement.
Can you come again?
Recruitment. Consent, how the piece of future has come about. And I think you can also benefit example. Research conflict from fellow population and how this is kind of executed this last relationship. And also like question of resistance and agents. It's not always about resistance. So there's also collaboration where, traditional chiefs collaborated with, our officials.
Okay.
Okay.
Okay. Thank you. Thank you very much. So we in the back. Okay, so I'll come to you. 30 seconds.
So my talking about
Talking of ethical tourism.
Medical tourism.
Ethical tourism.
And those who use facilities, was there anyone that their conditions after using our facilities? And also,
Is it child?
people who fund
Zero
now,
lights.
and those who are not ended. Are they local for people to be honest? All right, thank you.
Thank you, presenters. My name is Nicola from Mappa. I remember at Nata Ward then, we requested them to fund the TV for us, and they asked us to contribute money for subscription. One of the hospitals at the Southwest. Please, I want to know if your ward would suggest some recreational activities that could help someone with chronic illness or trauma. I would like to.
Thank you.
Okay, my name is Chika from Life Investing, and my question is also kind of clarification. I know about arts intervention, like arts influencing. I've been a fan of such programs. Is there really a difference between arts intervention and the recreational activities you're talking about? Because they are all towards making the patient better. Thank you.
Okay.
I was just going to talk about I'm still working about taking Natal colonial masters and so on. We are just working the colonial aspect of our development and all that. The elite, I just just to look at what I have been solution to the elite theory. And my view is that you could say from
Let's
the elite are actually part of our problem. It's no longer colonialism. But I mean, I'm saying that there must be some other explanation other than colonialism. After almost 50 years post colonialism.
Okay, thank you very much. Which
Okay, for the first concept of medical, yes, it has a relationship with economic development, like leads to the infrastructure development and even employment, creates employment. If I give you an example, in Afghan, because of the hospital in Afghan, we have a transit unit, another gate that used for patient treatment that generates money for the hospital. So yes, actually help. The patient using this facility, any health promotion, why patients were not my respondents, I use healthcare professionals, but then confirm that patients that they have recommended this facility, that there are improvements, like fast operation, emotional security, and social interaction. Maybe further study, I can use patients. Recreational facilities for chronic illness. I am not an healthcare expert to recommend that, but I will factor that to ask them if you're a recreational for chronic illness. At intervention and safe. A recreational facility is not just art, it can be music facility, it can be games, it can be garden, anything that's not medical. It's actually help them in well. Thank you. Okay, I just make things about the something that's online business. And that is very the only reason why kind of punishing where the punishment ordinance. So actually that's not really reason because during that period people were used to this personal medical system. Yeah. And they always go to the so for them to be able to test their medicines, to use it, so they can't test on themselves, of course. So and it's not just the visual something. And even the word visual, how did first I just on this I want to say that it's not punishment is not just because of the visual aspect.
Okay, it's not just because of which. The people need to come and take the vaccine. They refuse to take it because they are giving it to them. They refuse. So there's punishment if you don't want to take the vaccine. That's just what I'm trying to say.
Thank you very much. We don't have time anymore, but I think before we leave here, we must reiterate that the panel centers around public health humanities, and we're trying to see how humanities are thinking and help us refine the way we approach health issues beyond the clinic. And a lot of questions that have been raised, by the presenters and also the audience reflect some of these issues. So, for me, while listening to Oluwatosin, I kept thinking about health resistance. What does it mean? How is it framed? I struggle to understand this idea, within the context of the work. And also, some of the images, that I saw pop up, I kept wondering that whether interpretatively, visually, the way the person on the picture is actually represented as colonial officer, whether that is the case, because we know for a fact, that local health officers also dress as such, but that person really look great. So I don't know what it is, So these are methodological issues, right? The way we visualize, the way we think about images, and how we get to the interpretation of images. And that comes to the issue of methodology that was raised by Dr. Tolu. Also, Precious talks about very interesting issues as well. But then, in terms of robustness of analysis, colonialism, what are we missing out? What are we missing out? What are the points we are supposed to be missing? But also, again, humanity, how can we use indigenous knowledge to think about the kind of issue that you have raised? So we propose theories, Western, obviously Western theories, but also, please, if you want to leave, you can leave quietly. We are hearing murmuring. So culturally, what does medical tourism mean? Do people go to? Look at it. People go to health facilities to watch TV, to play games, to enjoy the environment, and given that the perspective of patients are missing, how can we tell actually that people sort out those healthcare facilities because of the recreational things that are there? So I want you, for instance, reconcile being ill and thought the idea or the notion of tourism as it were. So we need to elevate discussions, and we still have multiple panels for today that will still be exploring different aspects of health, public health humanities, and we are trying to invite you to show up at that meeting. Shegun is still raising up his hand. Bjorn, oh, that's
Thank you. Very good. My Olga talks about outdated theory. That's problem. And as a literary theorist, I want to suggest something quickly here. Can you please look into conservatism as a theory to interrogate your work instead of colonialism? Conservatism means more current and make your work more current than talking about coloniality. Thank you.
Okay, yeah. So thank you once again to Tosin, to Precious, and also for sharing your research with us. I'm sure some of our audience members there, they have questions for you, they want to talk to you. Please interact post this session, and we'll see you after lunch at the next panel of Public Health Humanities. Thank you very much. Thank you.
Thank you, Chair.